The intention of this part 2 session is a bit more of a welcome specifically for our Wave 2 sites, and to start to go into a bit more of the detail from what we presented in part 1 in relation to what proactive care is. So we'll be touching on work for serious mental illness, which Matt and Beth are going to lead on for us straight away, and then going into a bit more in detail around the essential components for proactive care and the implementation support offer. Just in relation to some housekeeping, we're going to run this a little bit more informally, this part, so please feel free to have your camera on. You're allowed to for this part of the session, and you are able to kind of unmute yourself if you need to come in. We've got quite a bit to get through, as I mentioned, so it would be really helpful as we go through, if you've got questions, if you can post them in the chat. And then we'll hopefully have time at the end to come to those and bring people in, and you can unmute yourself and ask them verbally if you will. I think that's probably all I just wanted to say at the start. Jana, Katie, Daphne, Matt, anything else that you want me to cover for this bit, or are we good to dive right in? Okay, fantastic. So Matt, handing over to you first of all. And I think we are doing it as well.
Thank you.
Welcome.
Thanks very much. So you heard earlier about the wider physical health frameworks that we've developed, and we've also in the process of developing a framework for people with severe mental illness. And many of you will know this, of course, that people with severe mental illness do die much earlier than people without severe mental illness. But they don't die generally of their severe mental illness. They die of cardiovascular disease, of stroke or heart attack or cancer or COPD exacerbation. And what is very common in population of people with severe mental illness is this high prevalence of high impact but highly modifiable conditions, blood pressure, cholesterol, diabetes, etc. And we know there's a very clear evidential line, a very strong evidence base that if you optimize these conditions, particularly the metabolic conditions like blood pressure, cholesterol, blood sugar, then you have you can have a substantial impact on preventing these life-changing or life-shortening events. So we've taken the approach of, so in this population, which has different needs and is more complex, can we apply the same sort of risk stratification, use of the workforce and targeting of interventions? And we've built on, or combined with, a programme in North Central London, in Camden and Islington, that has been going for a number of years, called Primrose, in which they've done very innovative things to try and improve the engagement of patients with severe mental illness, engaging them with their physical health, having a patient-led approach and a stronger support for behaviour change strategies. So can I have the next slide, please? So in combining with Primrose, we've essentially brought the stratification and the workforce elements to this and the new models of care. So the stratification, and I have to emphasize, this is all in final stages, but still is draft, but this is broadly what it will look like. So we end up with 4 priority groups, driven by factors that give us some insight into urgency in which patients need to be seen for their physical conditions. So blood pressure not controlled, diabetes not controlled, not on appropriate statins for their cholesterol in primary or secondary prevention, not on anticoagulants if they have atrial fibrillation, a particular group of people with obesity who are also on antipsychotics. And then you see the priority groups. Priority 2, we don't have a recent blood pressure reading as a proxy for lack of engagement, for example, and then other patients. And the next slide, please. And I won't do any detail on this, but it's just to give you this sort of an overview of what it would look like. So we have the prioritization at the top there, gives us the clinical prioritization. Who do we need to see early? Who can we safely phase to later from a physical health perspective? But of course, the complication for people with severe mental illness is that their illness may be severe, they may be in a complex condition, they may be unstable. What are their mental health needs? Because that's going to determine how we look after them physically and their flow, as it were, their journey through the pathway. So it would start with a desktop review by a mental health nurse who would have access to the GP and community mental health records, both to assess the complexity for the patient. Do they need intensive mental health support? Are they unstable at present? what are their needs to engage around physical health? Are they pretty stable and likely to keep their appointments, etc., or will they need more intensive support across the pathway? And then you see the centre box there that the desktop review mental nurse would determine who needs to see a mental nurse for close oversight of what happens next. And that in the centre, the nurse would review their mental health and wider needs, and then provides more stringent oversight of their engagement and patient journey, but would also refer them for the proactive care appointment and the physical clinical review appointment. On the left there, the proactive care, as we've described it, delivered by someone like a healthcare assistant or wellbeing coach, etc., would do the physical checks, get the blood tests and readings up to date. In the same model as with the physical care, support, education, self-management and behaviour change for those patients, but to have that enhanced for this particular group of patients with resources and training for the staff who would give much more careful support for adherence, for actually embarking on more in-depth support for smoking cessation, etc. But then also a pathway for patients who want more intensive support, a pathway to that could be delivered by, for example, a peer support worker, which was used in the Primrose model. But the staff can also refer for the patient to address some of those wider needs around employment or benefits, etc., that may be identified, referring to social prescribers or care coordinators. And the staff would also be trained to recognise not just the physical health red flags, but mental health red flags, social red flags, so that they could refer appropriately. The clinician would then follow up, probably a nurse or pharmacist rather than a GP. That could come first if the patient's clinical readings were very unstable, for example, but essentially they would provide the clinical optimization. And as with the HCA type appointment, this might be in one appointment, but there might be multiple follow-up appointments to get the high impact, highly modifiable conditions optimized. And on the right there, you see there would be more intensive support for patients who need much more help with engagement, patients at home, for example, but also specialist mental health support to make this work. Now, there's still quite a bit more work to do underneath this, but that's the broad approach: stratification, use the wider workforce, build on the great stuff and that's been published in the Lancet from the Primrose model, but focus on, so how do we make this real world deliverable in real world primary care across the country. So I'll stop at that point and hand over to Beth.
Thank you very much, Matt, and welcome. Beth, I know you've introduced yourself in the chat, but you're Programme Manager for the Adult Mental Health Team in NHS England and Improvement. So welcome, Beth.
Thanks, Laura, and thanks, Matt. Really helpful intros. I'm really pleased to be here this afternoon. I think I'll probably just start by saying when Matt approached us to talk about scoping doing a particular piece of work on Primrose, I think we were all really excited about it. The original published paper that Matt's just referenced showed some really good outcomes for our population cohort. So we're really excited about this piece of work, and we think that it aligns perfectly with some of our ambitions in the long-term plan about improving physical health for people with severe mental illness. So I've just got two really brief slides. The first one here just sets out how our physical health for SMI programme kind of fits within the broader community mental health transformation programme. And then I've got a second slide on the all-important question around investment available to support this transformation programme. So this slide here just sets out our key commitments as part of the NHS long-term plan to transform community mental health services. So we've got 5 key areas that we're focusing on as set out in the long-term plan. And then the one right in the middle there, highlighted in green, is our ambition to improve physical health outcomes for people with severe mental illness. So our commitment in the long-term plan is that people with SMI receive a comprehensive annual physical health check and then appropriate follow-up interventions after that as well. And the target for the end of the long-term plan is that just shy of 400,000 people receive that annual check and follow-up interventions, and we get data on that on a quarterly basis. So at the minute, all of our STP ICSs kind of report on that data on a quarterly basis, and we get a sense of where we are against our trajectory. So the next slide just sets out the investment that's available kind of across the entire community mental health programme, and then I've set out the funding that's available specifically for the physical health element as well. So by the end of 23-24, there'll be an investment of around £1 billion of new funding per year going into community mental health services. So this is a really exciting investment. It's going to be the biggest investment and transformation of community mental health services, I think, since the NHS began. So lots of great work backed by some terrific investment as well. So on the left-hand side, we've just split out how what that investment profile looks like for the transformation programs. We've got transformation funding going into each of our STPs and ICSs, and that's followed by a transformation planning process each financial year, where each of our STPs and ICSs kind of set out what pieces of work they'll transform and how they'll use the investment across the portfolio areas set out on the earlier slide. And then there's annual increases in CCG baseline funding across the piece. And then for this financial year as well, we were really lucky to land some additional funding as part of the comprehensive spending review, specifically for community transformation. And then specifically within that, we landed a 12 million allocation for physical health checks. And within that, we've set out that so that funding was allocated to each of our STP, ICS footprints on a fair shares basis. And we set out within our delivery plan that we were looking for systems to commission what we're calling a tailored outreach service, which is essentially a service to support people with SMI to access their physical health checks and or their flu or COVID vaccinations. And I think that was where we kind of spotted the alignment between this and the prospective piece of work on Primrose with Matt. And actually the message that we've been cascading through our side is that using that outreach funding as a kind of way to support the funding of the Primrose piece of work is a completely acceptable use of that funding. So any STPs or ICSs that are interested in working on the UCLP piece around Primrose and SMI, we'd be really, really happy to support them to utilise that SR funding to support this particular piece of work if they don't already have plans in place to utilise this funding. And then on the right hand side, that's just a visual representation of kind of how that funding is split out across each of the areas as well. So for physical health, there's still CCG baseline funding, there's the SR funding that I've just mentioned, and we have also invested quite heavily in incentivising all of the elements of the check in the quality and outcomes framework as well. I will pause there. I think that's it from me.
Thank you very much, Beth and Matt. And I posted in the chat just before, so we have got a number of our Wave 2 sites who've already indicated they want to do the Primrose model as part of implementing proactive care. So it would be great if any of the other sites also do want to do that focus. And very helpfully, Beth, you've kind of pointed out additional kind of funding and funding streams they may be able to access to do that. So thank you. So I'd now like to hand over to Daphne. He's going to talk to us about the essential components of proactive care. Welcome, Daphne.
Thanks, Laura. So everyone, I'm Daphne Mavenu, Deputy Programme Director at UCL Partners. I'm just going to give a caveat to say I've got a bit of a cold, so apologies for my voice cuts out throughout the talk. So if you can move on to the next slide. So really excited, one before. We're really excited to have you all on board to join our existing 4 pilot ICSs to implement proactive care at home. And as it's been mentioned already, we really recognise how much pressure there is on the health and care system, particularly those in primary care. So thank you for committing to working on this programme. But we really do want to make sure it's not seen as an additional thing to add to your very long to-do list. As Tim mentioned, it's very much a vehicle to deliver on existing commitments and ensure that our patients are getting the best support for long-term condition management and are able to self-manage as best as possible. So through the experience of working with our pilot sites, but also working on general other interventions around primary care change and healthcare interventions previously, we've identified a number of key pillars and essential components that will help you to implement this approach sustainably and really get to the point of transforming long-term condition management in primary care. If you move on to the next slide. So the key pillars we've identified is firstly strategic engagement. So it's really important to make sure you have the key stakeholders in your local systems on board and bought into this work. As I said, we don't want it to be seen as an additional bolt-on, so we want people to grab hold of this and see it as a key tool to help them deliver on your local priorities and your ICSs. And very much linked to that is local clinical ownership. We don't want this to be seen as a top-down initiative, and really grab onto the frameworks and adapt it to fit your local system, and build it into your approach to long-term condition management. That really is key. And there's plenty of flex in our frameworks. It isn't a blueprint. It's a way for you to structure things and think about how it fits into your local approaches and ways of working. As Matt mentioned earlier, workforce transformation is a key piece of this. We really want to involve the wider roles in the primary care workforce and think about how to better engage them. And we had some examples of things that are being done already in the system. So that really is a key pillar in this. Levers have come up as well, so financial incentives, how that can be used as transformational levers. I popped in the chat in the previous session a document that talks about some of the financial incentives that can support implementation of this work, but there will be lots of opportunities for you to identify how you can link into local level initiatives and incentives. Metrics and data collection, as always with any piece of work, this is really key. It's important to identify what really are you trying to do and what are the key metrics that you'll need to track to understand how you're progressing and the changes it's making. And given what we know about the challenges in primary care data collection, it's really important to think about this up front to support the work you're doing. And the final pillar is governance and project management. So it's really important to make sure that, particularly in this changing landscape in the system, moving from CCGs to ICSs, that you're linked into the new groups that may be coming up around either long-term condition management, personalised care, and think about how this really can be embedded in the new ways and the new systems that are being set up. And project management is always key to make sure you're moving forward well and continuing to work towards the overall aim that has been set up initially. So we move on to the next slide. So these are essential components that we've identified, and I think a number of these have been shared already in terms of identifying your SRO and named clinical lead. So really want to focus on points 5 to 7, talking about the initial phases of implementing this and what it is we expect you to do. And we recognise this is a journey, it's not a one-off project that you can work on. So we want to take a phased approach and really ensure the key foundations for successful implementation are built upon in the next 6 months or so. And point 7 just talks about some of the expectations we have of the sites participating, and it's not to task manage or performance manage, it's just to make sure we're all on the same page of what's a realistic expectation, and it is very much a minimum. So if you want to go faster, and because you've got the kind of conditions already set up, we very much are happy to see that happening in the systems. So move on to the next slide. So our key phases of implementation, we've identified 4 stages, although 3 are the really active stages. So engagement, and this is an ongoing journey of engagement, as it is a transformational piece with the aim to socialise the frameworks in your local system and really understand what are the local needs and challenges and how the frameworks align with that. And we would expect ongoing engagement throughout all of these phases, but at the beginning it's really important to make sure you're investing time in doing this up front. The next phase is then kick off a mobilisation, which is an opportunity to build a shared understanding with the various stakeholders in your system about how to adapt the frameworks to fit into your local needs and priorities, and thinking about who are the key partners who need to be involved in the implementation of this to support a really successful approach to using the frameworks. And the implementation phase, this is where you actually get going and are able to use the frameworks and see patients in a different way. And really the aim here is to overcome any barriers that are arising and sharing key knowledge at PCN and ICS level to make sure that people aren't tripping over the same thing when someone else in the system has already come up with a great approach to overcome this. And then the last stage is around business as usual. So at this point, everyone is bought in to doing the frameworks in a great way, kind of figured out the kinks and different issues in the approach. So that's our kind of last stage, and we hope systems get there probably over a couple of years' journey. So if we move on to the next slide, it just highlights the 2 phases that we've already referenced and we want you to focus on for this current financial year. We've got about 6 months left in this year, so really the focus is to work on your engagement and put things in place for the kick-off the mobilisation phase to get going for implementation once we're in the next financial year. So moving on to the next slide. It's given a bit more detail about what it is we expect to happen based on the experience we've seen in the 4 pilot sites. So as mentioned, the aim of this phase really is to socialise the frameworks, and the key activities here is just talking to lots of different people, so identifying your key stakeholders, working through what the local priorities are, where there are existing projects already that are linked to long-term conditions, personalised care, maybe medicines optimisation, and thinking about how the proactive care frameworks can really support to further progress those projects. And through those conversations, you'll be able to identify the key challenges and barriers that there may be in using the frameworks. So holding engagement sessions, which is what we've done elsewhere with those stakeholders, is a really effective way to have the open conversations to get people to share what their concerns or interests are in implementing the frameworks. And we've got a number of resources on our website which can support you through that. The next slide, please. So in the kick-off and mobilisation phase, this is where you're doing more of the kind of groundwork to set up their foundation to move forward. So key things to highlight here is starting small. So don't plan to do everything in one go, because there are so many different things you can do with the frameworks. So what we've seen has worked well is identifying a number of pilot sites to be involved, and then being clear on what it is you want to see from their experience. That can then inform a broader rollout approach. And also potentially inform how you want to align local incentives with the work. Identifying the local clinical commissioner and project management leads for the work, and thinking about whether you need to get your training hub involved and other kind of key system partners. Also linked to starting off small is really thinking about which patient cohort you'll focus on. So as it's been mentioned, there are different priority groups for the different conditions that the search tools allow you to identify. It'll be helpful to say, okay, we're going to focus on our priority 1 patient who've got this particular condition. So running the searches at a local level will help you understand how many patients you're dealing with in those different groups. And it can also help you to think about what the health inequalities are in your system. And that can inform the choice of which PCNs and practices participate in the pilot. Next slide, please. So linked to running the searches is, once you know how many patients it is that you want to support, it's really thinking about your workforce, so identifying the number of staff needed to support the different patient cohorts, and what training and support they need to be able to work in this new way. Patient involvement is key, so it's really important to think about what your approach will be and any educational material that you might need to put out there to help patients feel comfortable with a different way of working. We've mentioned data and evaluation as one of the key pillars, so this phase is really when you would invest the time to think about this. And then it'll be important to adapt the frameworks and think about what are the particular social prescribing referral pathways, for example, that may be in your system that you'll need to feed into the frameworks. And digital tools can be a real enabler, so thinking about what tools can support the work and what tools are already available. We recognise BP at Home has been running, so systems have BP monitors, but there are many other tools, which again we've listed on our website, that can be used to support implementation. And of course, thinking about how are you actually going to share learning across your systems and use quality improvement approaches. Next slide. So just wanted to give an overview of what is expected in the implementation phase, but as mentioned, we don't expect you to do this in the next 6 months. So it's when you get going, you're implementing your adapted pathways, running your community of practice or shared learning forums, and just continuing to keep track through metrics and local system experience of how you may want to continue to adapt the frameworks to fit in with the work you're doing, and making sure you have a constant eye on upskilling staff to make sure they're always at the top of their competency level, but also giving new joiners the relevant training that they need. So I think that's my last slide. Yes, thanks. So I'll hand over to Jenna.
Great, thanks very much, Daphne, and welcome, Jenna.
Hi everyone, my name is Jana Lloyd. I'm the National Programme Manager for UCL Partners. So I'm going to take you on a bit of a whistle-stop tour of the UCLP support tools. Now this is about actually how do we make this happen in real life, and what we've done at UCL Partners is we've developed a whole bank of resources for you to access. These are all absolutely free, so please just jump onto our website and have a look. When these slides are circulated to you, you'll have all the links available as well, so you can just click through and have a little play around. So the main website can be accessed through the main link, which is at the top of the page. And then the second bit, what we've done is we've really tried to break down, the background and context of the frameworks and really what the frameworks incorporate. So once again, you can click through. What we've also done is we've provided lots of videos And these are bite-sized videos. Some of them are longer, some of them are sort of 5 to 9 minutes. So, so it's like if you want to send links to colleagues to watch just so that they can understand what this is, because it's such a large program of work that it can be quite hard to conceptualize it all. So the videos really help break down the initiative to give you a real sense of what the frameworks are. And then if you go on to the next bit, which is the implementation support. Oh, no, sorry, not the next slide. Sorry, go back. Thank you. The implementation support, we've broken it down into 3 phases, which is the engagement phase, kickoff and mobilization, and the implementation phase. So as Daphne mentioned before, what we've tried to do is really try to break down each phase. And we've attached resources that you can look at, you can download, and you can localize. So these are things that you can download to really make it so that when you're attending meetings, we've got agendas, we've got presentations that you can localize, and you can use it for your own benefit. We've got the search and risk stratification tools. Once again, it's free to download. However, you do need to sign up for them to be sent to you. The reason you need to sign up to this is because when we make changes or iterations to the searches, it's so that we know who you are and we can send you updates. But if you sign up, it's normally action within sort of 24 to 48 hours, you'll get all the searches. So it's all on there along with supporting resources. We've also got further breakdown of CVD resources and respiratory resources, as well as education and training resources for both conditions. So once again, they come with video packs as well as presentations that you can download and use for your own purposes. We've also got FAQs, and these are all benefits of our Wave 1 pilot sites. So these are all the questions that have come up, as well as we've also built a resource around all the frequently asked questions by PCNs and practices as well, which you can find in the engagement phase of the section. And then you can sort of join up to our mailing list, which means that we will send you updates, newsletters, so on and so forth. And then, of course, meet the team. So you'll get to see who we are. We've got images of all of us, so on and so forth. Next slide, please. Thank you. So what I wanted to do was just pull out 6 main top tips for implementation, and these are all based on, at the moment we're in the process of evaluating the Wave 1 pilot sites. The evaluation is led by a research team at City University, and these top tips have come from the interim evaluation report. The final report is due at the end of November. So the first tip is sort of choose the condition. So this is really around the starting point. Where do you start? So if you know the condition you'd like to start with, then you can start there. Or what we recommend you do is run the risk stratification tools and identify your priority groups in terms of which condition you'd like to start with. This doesn't stop you from taking a multi-morbidity approach. However, what it does, it gives you a very clear starting point. The next one is identify the right local champion. Now, we can't emphasize to you enough how important it is to have the right lead in place. And this is also about having dedicated time, relationship and influence to really champion the work, and having the right lead in place can really make the work flourish rather than stagnate. The next one, local and national incentives. So, can't again emphasize to you enough, this is not a new initiative. This is, the frameworks are seen as a vehicle of allowing you to deliver on existing incentives, such as your QOF, your IIF, your locally commissioned service, so on and so forth. So when you're presenting this work to colleagues, PCNs, practices, it's not about this new initiative. This is about actually efficiencies in delivering on existing initiatives. Next slide, please. The next bit is around informing your staff and patients, and it's quite important to do that because your staff and patients might not understand why, when they're coming in for a hypertension review, you've got someone talking to them about smoking cessation or alcohol consumption. So it's just about ensuring that staff and patients understand the holistic nature of the review that you're embarking on. The next bit is around workforce skills mapping. So this is really to ensure that you are identifying the skills needs and training gaps within your workforce. So this is to ensure that everyone is working to the top of their competencies. And one of the ways we recommend you ensuring that they get to the top of their competencies is by engaging your local training hubs to identify all the training support that's out there, to upskill a workforce. And the final one, as Daphne mentioned, metrics is really, really important. It's important to determine what metrics you're trying to collect. What is it that you're trying to achieve locally within your PCN or your practices? And it's important to determine this early so you can capture some baseline data so you can understand what progress looks like for yourselves. That's it from me. Over to you, Katie.
Thank you, Jana. So I'm Katie Welkin. I'm a senior manager in the at-home team. So I just wanted to reiterate, this is a local approach. It's about local implementation. But like Jana has just described, there are things that we are doing and that we have nationally that will help you with that implementation. So we'll be holding community of practice sessions. They're going to be topic focused and led by sites. And we have created an online community of practice, an interactive space on NHS Futures. And a joining link will be sent out in a debrief pack after these sessions. The team can also offer feedback and give advice on any implementation plans. And I just want to caveat here that it is important to note we are a small team, but we are happy to help where we can. And we are planning a mix of future support webinars and recorded sessions, similar to this one, but more in depth on certain topics, which does take me on to the next part of this session. Can I have the next slide, please? So we're going to be using Menti for this. So if you'll be able to either scan the QR code with your phone or click on the joining link in the chat, which has been dropped in. And what we want to hear from you about what's most helpful to support you implement proactive care at home and get some immediate feedback on creating a pipeline of future support topics. And you can, of course, get in touch after today with any comments, suggestions and feedback once you've had time to digest this. So if we could have the Menti on screen, Natalie, that would be brilliant. Now we'll quickly, lovely. You've all jumped straight in. So there was a list of topics. So yeah, of those topics, which ones would you like to see first? It lets you select up to 3. That's brilliant. I'll just pause a little while. I mean, I can see you've got your hand up. Are you okay there?
Yes, thank you so much. Just while you're getting Menti and things set up, I just wanted to make a general comment. This is so useful and so helpful. I'm a consultant cardiologist in North London, so Barnet, Royal Free, etc. So we're neighbours to UCL partners. And actually having this resource and the amount of time you've done the work in the first wave and then second wave, getting the feedback, this is so useful. One small question I had was, in one of the local places where Arlene said, look, we had some initial funding from AstraZeneca. How is the place of inviting third sector partners into this sort of work? Is that through UCL partners? Are they helping with that framework? I don't see any commercial representatives here at the moment, but I presume everybody wants to, support patients getting into the right place for the right reasons on the right treatments. Just a quick question, really, while you're setting up Menti, obviously.
Absolutely. Should we?
And Matt might want to take that.
Yeah. Should we come back to that one at the end, Laura?
Yeah, because we're going to touch on the AHSN support offer just kind of after this.
Yeah, come back to it. There's no rush. Absolutely.
Great, brilliant.
Absolutely. Thank you.
Thank you for that. So yes, it's a real mix and some brilliant feedback there. So we can certainly work on that for the sort of future support topics. Could you flick on to the next question, Natalie, please? Are there any other topics you'd like to see? So was there something there that you weren't, that you were expecting to see that wasn't there? Any suggestions? And there is a space for this on the feedback form as well, or if you wanted to reach out to the at-home mailbox after the session, then that's fine too. I'll just pause for a second. See some of the answers coming through.
Yeah, apply support. We're going to touch on that in this next.
Yeah, we are. So just
Yeah, we can move on to the final question. Again, you can feedback after this session, but just in relation to the wider implementation that you've heard about from Jana and I and the national team and the delivery partners, is there anything else you would like to see? Now, please feel free to still populate this, and what we'll do is we can move on to Daphne's presentation, which will cover working with the AHSNs. But yes, we would invite your thoughts and your comments on this. I'll hand over. Thanks, Laura.
Okay, thank you. So Daphne, I think this last few slides are from you.
Yeah. So I was just going to talk for a few minutes about the role that AHSNs can play in supporting implementation of this. So just to give a bit of background to make sure we're on the same page, academic health science networks were established by NHS England in 2013 with the mandate to spread innovation at pace and scale. And we are there to connect and bring together the NHS, academic organisations, local authorities, third sector and industry to really incubate and create act as catalysts to create the right conditions for collaborative working to ultimately improve the health and care system, and we have a real focus on improving outcomes for patients and the patient experience. So there are 15 AHSNs covering England. UCL partners, we are focused on North and East London and then surrounding counties. And just to give some examples of the work that the AHSN network has done, we're often commissioned to deliver national programmes. So we delivered a national atrial fibrillation programme between 2015 to 2020, and through that work, almost 12,000 AF-related strokes were avoided, and that led to significant cost savings for the NHS, so £158 million, and then 105 million for social care costs. And there's currently a national ADHD programme led by East Midlands AHSN, and the focus there is to support children with diagnostic element of ADHD. So 10,000 children in the previous financial year have had an objective assessment as part of their ADHD assessment process, and that's led to real savings in terms of the time between for the diagnostic decision by 5 months. So we're doing great work and are trying to work collaboratively with NHSE to continue to deliver on this proactive care at home programme. Let's move on to the next slide. So AHSNs can support in a variety of ways, and it will depend on the particular local model and capacity of the AHSN in terms of how they'll be able to support you. So UCLP are supporting 2 of the 4 pilot sites, North Central London and North East London CCGs. East Midlands AHSN are supporting Leicestershire and Rutland, and the Innovation Agency supporting Cheshire and Merseyside. Some of the types of support we've offered to date have been around implementation support tools, helping with the workforce aspect of things, supporting development of shared learning sessions, helping with the strategic programme design, project management, providing clinical champions to have the conversations with local system partners, and then supporting around comms and evaluation. And at the bottom, I've just given a screenshot of another AHSN west of England who are, whilst they're not supporting one of the pilot sites, have been very proactive in supporting their local area, and they've developed a great checklist which you can have a look at on their website to help people get going with the proactive care frameworks, and we'll share the link to that in the debrief. Next slide, please. And just to give a bit more of an example of how the specifics of how we're supporting Wave 1 sites, as I mentioned, UCLP are supporting NCL and NEL CCG, and the key ways we've been doing that is we've got dedicated project managers within the team who are supporting and collaborating with our key stakeholders, so coordinating engagement sessions which are attended by Matt and other members of our clinical team, and presenting at key meetings, so maybe at a PCN CD meeting or CD networks, providing coaching and practical support to local clinicians and operational leads to work through some of the bottlenecks. Our commercial and innovation team, they've been providing great support around digital tools. And just to address the question raised, all AHSNs will have some type of commercial innovation function. So in addition to the digital tools list that's on the UCLP website, potentially a local AHSN could support their local systems to identify what kind of tools are available, and obviously dedicated project management support as mentioned. So I'll stop there, and I think I'm handing back over to you, Laura.
You are. Thank you very much for that, Daphne. That was really helpful. And a few questions have come through in the chat, which we've responded to, but just in the last kind of 5 minutes, just wanted to wrap up really kind of like next steps. So I appreciate that these kind of part 1 and part 2 has been very much a whistle-stop tour of what proactive care is. And we very much see kind of today as the start of the conversation with our new sites in particular. So we will be circulating kind of the material afterwards, but kind of key next step really is getting that time in with all of our new sites to look at actually how we approach this and the plan. And I think an important part of that is making the connections with your local AHSNs and the support available. So UCLP have offered to start to make those connections, so we can kind of reach out to you and you can reach back out to us after this session, so we can make sure you're all connected. And we've done some intros, etc., in the chat as well, but we will start to kind of circulate kind of contact details as well for our new sites, so we can start to bring you all together as that kind of community of practice and making contact with each other. For us to do that, though, we do need to understand who the key contacts are for each of the sites. And there was a bit of a plea before this session for areas to start to identify the key kind of SROs for this work. So a further plea kind of after this, if you can go away and start to get that named contact, then we can start to really have those more detailed conversations about supporting you to think through how you want to approach this, what it is you want to do, and kind of the next kind of steps to help you on your journey, if you will. So just thinking if there are a couple other things that I needed to mention. So I did put in the chat, we'll be circulating a feedback form as well, so please do complete this. I know everyone kind of goes away and that they don't do it, but it will be really helpful and will help inform our future sessions and how we best support you. And it's been a bit of a download today, so hopefully it has been food for thought and you will go away and have some further reflections and further ideas. So that would be great. So I've only taken a few moments and there's a couple of minutes left. So any of our speakers, if there's anything that they want to add, please feel free to do so, or I'm happy to kind of have 3 minutes for if anyone's got a burning question they want to ask. Or equally, I can give you 3 minutes back of your lives.
Laura, should I just comment on Amit's question about industry? Thanks, Amit. So, yeah, really important question. Industry haven't had any sort of substantive involvement in development of the frameworks, but clearly industry are important partners in healthcare, and lots of local systems have relationships with industry, with care, to ensure it's all transparent and that their offer of support is clear and well understood. Some local systems, as we heard this morning, Knowsley, for example, working with AstraZeneca to support work around asthma and COPD, and no doubt local systems will do that. So that would very much be a choice for local systems, looking at how they resource what they're delivering.
Thank you. So if there are no further questions, then what remains for me to say as chair is thank you very much to our speakers today, but also huge thanks to everybody for joining part 1 and for those that have joined part 2 as well. And we